Thank you. Thanks, Clemens. Thanks for the invitation, kind invitation to speak to you today. And so, yes, I'm going to talk to you about the level of staff pay and its effect on care home quality. So, by way of an outline to this presentation, I will present some motivation and background, introduce briefly the overall research project that this work was part of, and then discuss the data we used for this. So this was a statistical analysis using secondary data, so not actually going into care homes, but using the data that's available nationally, and then discuss the findings, and then, as with most analyses of this type, there are always limitations, so I want to make clear those limitations to you before you kind of take those findings with that appropriate grain of salt, and then go on to discuss the implications of the findings, which I think are important for policy and for everyone involved in adult social care. Okay, quick disclaimer, just to say that the views that we talk about today are the views of mine and my co-author, Florin Verdain. Okay, so by way of an introduction, employment in social care, where it's generally low paid, there's high turnover, and there's the use of 0 hours contracts, so non-guaranteed hours. And I use this carefully in this room, they would be perceived economically as low qualified. But staff have high levels of informal skills, even those staff without formal social care qualifications, a lot of them will have multiple years of on-the-job experience. They form relationships with those they're supporting, so that's been discussed in a number of the presentations today. And overall, it is the staff that play the vital role, the direct care staff that play a vital role in the quality of care and the overall quality of life of residents. So, given its low pay and high turnover, does that low pay and potentially poor employment conditions, if you're thinking of 0 hours contracts and other factors going into employment conditions, does that affect the quality of care? Or conversely, if we're going to increase, if we're thinking about policy that's coming up, if we're going to increase pay and improve employment conditions, will that improve the quality of care? So one of the aims of our overall project was to assess the effect of staffing on English care home quality. Previous research, there is quite a lot of previous research in the US. From the US, it's often examining the effect of staffing on clinical markers of quality, so looking at more kind of process, so prevalence of pressure sores, readmissions into hospital. It's generally, but not always, finding a positive effect of staffing on quality, so sometimes negative effects of agency staff, for example, the employment of agency staff. There's limited evidence for England, but we've started to increase that research evidence and that research base. And our initial work, we looked at just cross-section and found a negative association between job vacancies and staff retention on care home quality. So, again, got a QR code for anyone that's interested in further details in this. And mea culpa at this point that this one, I've suddenly realised, is not open access. I could have sworn it was, so it's not free to read. But so for this one, I do apologise. But if you typed our names and staff retention into Google, there is a free copy on the university website, on the university repository, if you were interested in this one. But virtually all the others that I link to are open access and free to read, for those of you who are interested in further details. So, based on that, we look to extend that analysis as part of the MyCareHQ research study. So this was a wider project with 3 key objectives, with colleagues from the Brighton and Sussex Medical School, the University of Sussex, and then a couple of institutions within the University of Kent. And it was led by Professor Jackie Cassell and Professor Anne-Marie Towers, and it's the Measuring and Improving Care Home Quality study. And the aim that I'm going to talk to today was to assess the relationship between certain staffing conditions and the quality of care homes, and as I said, that's the work that myself and my co-author Florin Verdain led on. Okay, so I'll go into the details of what we did. I won't go into all the statistical details because it's late in the afternoon and I don't want to send you all to sleep. But I will talk over the data we used and then the findings. The data, in terms of being able to look at a national level analysis, the easiest available data in terms of quality is CQC quality ratings. So it's I'm sure most of you, or virtually all of you, will be aware of what it's based on, constructed in 5 key questions, asking if the care home is safe, effective, responsive, caring and well led. And homes are given one of 4 overall ratings, either inadequate, requires improvement, good or outstanding. For our analysis, we grouped them into 2 types of quality: lower quality for those homes rated as inadequate and requires improvement, and higher quality, those rated as good or outstanding. There were changes in ratings between the groups over time, for both within our sample and nationally. So that means that care homes rated as inadequate and requires improvement didn't just stay, it wasn't static. They did change, some changed to good and outstanding, and vice versa. Some did go down as well. We grouped them into 2 groups for a couple of reasons, mainly because if you're rated inadequate, that's a temporary kind of rating that ultimately would lead to closure if you didn't improve, and so the care homes had to make a number of changes. And so we grouped them into 2, and as the next slide shows, there's also a very small percentage of care homes rated as outstanding. So this is in our sample of care homes, which I'll get to explain what size sample we had, but it's a good size sample of care homes. And we split this graph into the nursing and residential homes, and then by sector as well. And you can see the differences there. So the majority of care homes are rated as either requires improvement or as good, with a very small minority rated as outstanding, either in nursing homes or residential homes. And the voluntary sector tends to have a slightly better level of quality than the private sector. So that's on the quality side. If we're looking at quality ratings, for workforce, we needed data on staffing. And so to do that, we used the adult social care workforce dataset, which is provided by Skills for Care. So social care providers voluntarily submit their staffing information to this dataset. It's got about 50% coverage nationally of all adult social care providers. And for research purposes, we can have anonymised data at employer and employee level. And so we can't identify employees in any way other than who they work for, but we also can't identify who they work for. The care homes or the home care providers that they work for, we can't identify. We use this database annually across 3 years, October, for 2016 to 2018. And the measures of pay were, we used measures of pay, which is average hourly wage. In terms of our measures of staffing that we were particularly interested in, we looked at average hourly wage of direct care workers, and then training in terms of 2 measures of training proportions, so the percent of staff with dementia training and the percent of staff with training in dignity and or person-centred care. In terms of our sample size, this is we looked at care homes for older people and or those living with dementia. So that nationally is about 11,000 care homes, give or take, at that time. And we had across the 3 years just over 12,000 care home observations of around 5,500 care homes. So we had about half of all care homes in our sample, and each year we had around 4,000 care home observations, so we've covered more than a third of all care homes in England in our analysis each year. And over 2,500 were present across all 3 years. So just to take you back to our analysis time. So this is always a problem with research. When we started this project was in 2017 to 2020, this project ran, and then it took another couple of years for the paper to be published. So we're always using old data, it seems, even though at the time it was the current level of data. So just to take you back in terms of national living wage, it was being introduced in April 2016, and it was at £7.20 in April 2016, and then changed to £7.50 in 2017 and £7.83 in 2018 for those aged 25 and over. And the previous research in the national living wage in social care has shown that increased wages but compressed the pay distribution. So meant that the returns to experience and the returns to seniority were reduced. There was also a limited effect on employment, but it did reduce the total hours of work slightly. And there was an increased use of 0 hours contracts, or at the time, 0 hours contract, the prevalence of 0 hours contracts was actually dropping at that time. So it slowed down that drop in 0 hours contracts. And then I can show you the averages wage, so the direct care worker wage, average wage by sector, type of home and care home quality for our sample across all those 3 years. So we've got the private sector on the left-hand side, the 4 bars on the left, the voluntary sector on the right-hand side of the graph as you see it, the 4 bars on the right, and then we've got that separated, each 2 bars within those 4 for nursing home and residential home, and then by level of quality in terms of inadequate and requires improvement, the lower level of quality on the left-hand bar, the darker colour, and on the right-hand bar, good and outstanding quality, the higher level of quality as we were recording it. And so you can see differences in pay, a descriptive difference in pay by care home quality in this graph. So even in the private sector, the difference wasn't that marked, but we've got a large number of private sector care homes, so the difference wasn't as great, but still a higher average wage for those care homes with higher care home quality. The difference is more marked in the voluntary sector, although admittedly the voluntary sector has very few. The sample for those with lower quality in the voluntary sector is much smaller, so that might be affecting that difference. But what you can also see is the difference in the average hourly wage between the private and voluntary sector is much higher in the voluntary sector, and we have previously shown, and other evidence has shown, that the voluntary sector tends to have higher quality than the private sector in terms of delivery of care home quality. Now that's important because if we're trying to analyse the effect of staffing on care home quality, we need to control for all those other factors that could influence care home quality, like the sector of the care home. And so we did that. The statistical analysis, we use robust statistical methods. As I said, I'm not going to go into the details of them in this presentation, but we think they're pretty decent methods. We assessed the causal relationship. We controlled for some issues that could be important in this analysis. So, for example, the circularity in the relationship between quality and wage. So we're hypothesising that wage improves quality, but it could quite equally be that care homes rewarded staff for an increase in quality by giving them a higher wage. And so there's that circularity. It might not just be that wage influences quality, it could be that quality influences wage. So we needed to control for that in our analysis. And then, as I said, we controlled for other factors that can affect quality. So at the care home level, we're able to control for the type of home, residential nursing, its sector, its size, and also local competition, which we have shown before influences the level of quality. We could then include staffing indicators as well to try and control for differences in levels of skills between care homes. And so we include measures of training, as I've mentioned, the training measures, the staff to resident ratio, senior care worker to care worker ratio, and for nursing homes we're also able to include another measure of skill mix, looking at the percent of staff that were registered nurses. We didn't have information on residents. It's kind of one of the key limitations that I'll come back to in this analysis. So we use local area measures, local geography measures for levels of needs and levels of wealth and income. So in terms of levels of needs, and wealth, we were assuming that care homes, most residents in care homes will come from their local geography and from that local area, surrounding area. So we didn't have information on the level of needs, and we didn't have information on the level of self-funding residents, which could be important in terms of our analysis, which I'll come back to later on. Okay, findings. We found that wage had a significant positive effect on quality. So after controlling for all those other factors that could influence quality and using our robust statistical methods, we found that a 10% rise in wage would increase the chance of higher quality by 7%. So increase the likelihood of a good or outstanding rating for the average care home by 7%. Other things equal. These findings were robust to the inclusion of a measure of skill mix in nursing homes, so robust to the inclusion of registered nurses proportion in the nursing homes, and there was a stronger size of effect in nursing homes as well in terms of that level of quality. It was 10% increase in wage increases the chance of higher quality by 8.5%. We also helped to show that the circularity that we controlled for, that circularity of the quality-wage relationship, actually reduces the size of the effect. So if we didn't control for it, we would have underestimated the effect that we found. We looked at the underlying key lines of inquiry as well, and were able to show that wage affected each of those as well in terms of the ratings for those, if we did a binary rating for those as well in terms of lower quality and higher quality. So that ranged from 2% for caring to 6% for well-led for a 10% rise in wage, which is kind of what you'd hypothesise. You'd hypothesise that caring would have the least likely effect of wage because people will care naturally. And whereas well-led, you'd think that's a provider-led thing and is showing good quality leadership. We also found, in terms of our findings for staffing, we found that the proportion of dementia training improved quality, and that was kind of a 1 percentage point rise in the proportion of care staff with dementia training, improved the likelihood of higher quality by 1%. And generally, care homes that support those living with dementia have lower quality, we have found in previous analyses. So that's a decent finding that training could help with improving quality. So in terms of limitations, so we found that improving wages can improve quality. Thank you. In terms of our limitations, I'll have to rush through these a little bit. We've got, as I said, we've got needs levels and personal resident characteristics, in particular self-funding, whether their income levels and whether they're self-funding are not known. These things could influence the quality-wage relationship, particularly self-funding levels, because that would be a direct thing between. It could just be that higher levels of self-funding, people who are self-funding, who generally pay higher prices for their place in their care home, will lead to the higher quality and also lead to the higher wages for staff. We believe that our statistical methods have addressed this to at least some extent and hopefully completely. But we'd need actual information on self-funding levels and more refined data to be able to assess that in totality. We also don't know what the impact of wages are on actual resident care outcomes, on quality of life, for example, but CQC, because we've just been looking at CQC ratings. But we can show that the CQC rating is based on the mum test. Would you be happy with your mum receiving care from this provider? And we've shown in a number of small research studies where we've gone to care homes and measured residents' quality of life, that there is a positive correlation between their care home rating in the care home they live in and their quality of life. So there is a seeming relationship there to that. I'll briefly touch on the implications and maybe we can talk about those more in the Q&A because I'm running out of time quickly. What are the implications of these findings? Well, social care employment in 2024, wages are low compared to other jobs. So compared to healthcare, where a lot of social care staff will move to, compared to supermarkets, and compared to retail and hospitality. What research can show is that wages and conditions can reduce turnover in social care, and we believe, and we're also finding as well in other research that we've been performing recently that it should increase overall labour supply as well. If we improve wages, the overall amount of labour working in adult social care should increase as well. What we've done in this study in particular is found a further positive effect of wages on quality of care. And I think that's important because in terms of making appropriate policy decisions, as we weigh up the costs of increasing wage, we need to know what all the benefits are. And so the main benefit is going to be, hopefully, an increase in employment in social care and a reduction in turnover. But also, if it's having knock-on impacts on quality of care, and it's improving quality of life, and it's reducing NHS use, then we are going to be making savings elsewhere as well. And then one final slide to talk very briefly, very quickly, as I'm out of time, on recent policy from the new Labour government is the Employment Rights Bill, which has gone through its second reading in Houses of Parliament. And that proposes an adult social care fair pay agreement. And also that all those working on 0 hours contracts will have the right to come off them. I won't talk to that one too much, but in terms of the adult social care fair pay agreements, if there was to be a fair pay agreement policy that increased wage in the whole sector, well, the economic theory that we based our analysis on applies across an industry as well. It's been shown in research evidence that higher wages compared to other industries can lead to reduced staff turnover. It can lead to a better quality pool of applicants for that industry with a higher wage. It can lead to better effort. It can lead to better morale. Now, a couple of those things might not necessarily quite apply to social care, which, you know, is kind of, it's a vocation and people really already want to work in it. And so the better effort and better morale might not quite apply to a certain extent, but certainly reducing staff turnover would be crucial and improving employment overall. But of course, and this links back to the very beginning of today's presentations when Jenny talked to us about the budget, appropriate funding is required, and that's going to be important if wages are to increase. So I'll stop there, and thank you very much for your time.
Thank you, Dr. Allan. Could I invite last questions, please?
Hi, thank you very much for that. And I've been aware of some of your work around this, which I think is really interesting. I'm Diane Bunn, I'm a hydration care researcher from the University of East Anglia. I just wondered, in your analyses, did you look at geographical location at all in terms of urban versus rural? And the reason I ask is the smattering of papers that I'm aware of, that sometimes there's a difference in outcomes between care homes situated in those locations being slightly better in rural locations, and something I found as well, although small study and I haven't ever published. So I just wondered if, and also I'm not quite sure of this, am I right in thinking that average wages are slightly lower in rural communities? I'm not quite sure of that, but I just wondered if that was something you'd looked at. Thank you,
that's a really interesting question. In terms of that particular study, we were able to control for the region. I don't think we looked at a rural-urban disparity or any differences, but that is something we are looking at now and continuing with our research and looking at whether there are differences to the supply of social care based on socioeconomic differences across locations. And then in terms of wages in rural and urban areas, no. I haven't looked at that, but that would be of interest as well.
Yeah, Richard Ayres, Care England. It was very much aligns with what I thought you were going to say, so that's fantastic. I think just to touch on what the lady said earlier, in terms of rural versus urban, I don't know so much there, but in terms of the North and Midlands versus the South, I think it just brings in the other point you raised around the uncertainty of the impact of self-funders. I think my understanding from some language on research is very much that there's a greater propensity of self-funders in the South. So to average nationally could could skew the data slightly, but also the voluntary sector has a much higher proportion of self-funders who would generally pay more. So I think it correlates with everything that you said, and I think it's fantastic to actually kind of see it in an academic paper. What would be great is to find out whether you've got an appetite to kind of relook at that, because in light of the national insurance uplift and the fair pay agreement, probably going to take us till 2027 till we get that. This information updated would be incredibly helpful.
Yeah, no, quite agree. It is subject to funding. Yes, of course, there's an appetite for us to update this, and we'd be happy to do so. We're looking at things around this. So we've been, as I said, talked to briefly, we have been looking at how responsive people are to wage changes in the sector as a whole. And we've also done some research for the Scottish Government based on that as well, because they've had a sector minimum wage introduced there. And so they wanted to know how responsive employment in adult social care would be overall with that wage increase. So yeah, certainly.
Thanks, Helen Sims. Just to add another layer onto the geographical, I was thinking of the Chris Whitty report last year, which actually was showing that many people in older age moved to the coast and the peripheries, I think he referred it as, and often those might be poorer areas, and yet many of the workforce stay in cities for longer. So I think actually I'd be really interested in looking at it that way.
Yeah, no, quite. And I think I've definitely got a research interest in looking at that coastal, rural, urban. It is really interesting to me in terms of the supply of social care. Like, for example, I'm based at the University of Kent. In Kent, it's very difficult to get the supply of workforce for certain types of social care in certain areas. So in very East Kent, you can't get any registered nurses. And so you can't have any nursing homes because there's not enough supply of nurses there. Whereas in West Kent, when you get closer to London, you've then got that competing market for home care assistants, for care workers, and potentially higher wages in London. And so it's very difficult for that. And so, yes, I think the coastal areas as well is a very important area to look at.
I'm very keen on the coastal thing as well. I live in Norfolk and we've got a very big coast full of a lot of older people. And actually, Professor Alison Leary is doing a little bit of work around the Norfolk coast, so it might be worth you touching base with Alison.
Right.
My question was about the CQC ratings as to how old the CQC ratings were at the point of data capture, because we know that obviously a lot of these CQC ratings are several years old in some cases. And then, whether you actually dealienated that data within the study.
Yeah, that's a great question. So, no, we didn't delineate by when they were rated. I think our argument would be that was when CQC quality ratings were first being introduced. So we did have some missing data. So one of our statistical methods was to deal with that missing data. Because care homes hadn't been rated yet, and so we had to predict what their quality would be. So care homes were getting rated through that period, and so virtually all had been rated by 2018, but it was just being introduced. So we would argue, I think the timing of the rating issue is less of an issue at that stage, but I acknowledge the point that it's certainly an issue if we're doing it again. It's definitely an issue we need to consider. So thank you, and thanks for the tip as well.
My name is Harvey Rosenblatt. I'm involved in this charity. Is there any correlation between the working environment that attracts the best nursing care and the lack of investment in inadequately rated homes that would naturally not have that great working environment, and it would attract lesser staff?
I think, there's certainly another way to look at that is exactly what you're saying, is that the environment that is developed by management, that top-down kind of idea, that top-down environment. So using Emerson Nightingale as the example, fantastic top-down management in terms of how it's delivering for its care staff as well as for residents. And you're quite right, the relationship, it can be a knock-on effect that you start having lower quality, it then puts off staff, you have that high level of turnover, which then leads to lower quality. And so there is that kind of cyclical nature that we need to consider and be careful about when we're thinking about this analysis. So certainly, yeah, thank you. Thank you. Thank you.